Hi, this is Dr. Dan Guerra coming to you from Authentic Biochemistry Studios in the Inland Pacific Northwest. Today we're going to be discussing a couple of steroids, two in particular, that we've been we've introduced the glucocorticoids, so I'll say that. What we have not done is gotten into anything about vitamin D. Now, vitamin D could take 2 or 3 full-hour lectures to really establish anywhere close to a descriptive biochemistry of that really important steroid. Here, we're going to be really focusing it and relating it to glucocorticoids and a couple of clinical manifestations of morbidity and mortality in certain disease states, and particularly those associated with respiratory distress syndrome, associated rheumatoid arthritis. Okay, so that's where we're going. All right, so what I want to say here is, again, this is Authentic Biochemistry video lecture. There's my title: Vitamin D, Glucocorticoids, and Comorbid Pathophysiological States May Provoke Morbidity and Mortality in Humans. Today's the 22nd of May, 2020. I'm Dr. Daniel J. Guerra, and that is my email address. This is a free lecture. I would very much like it if you donated to either the YouTube channel or to my Authentic Biochemistry feed. And if you need details for that, you can email me directly. And of course, I do have a PayPal set up, and I'm working on Patreon. But this one's free, kids, and I think it's going to be very illuminating from the clinical perspective of the very current discussions we're having with a certain pandemic. So let's go. Sorry about that. All right. So not many of you are probably aware of the fact that vitamin D actually comes from cholesterol. Okay? Cholesterol in the dermis, in your skin. Okay? So you probably are aware of the fact that if you're exposed to UV light, which is a natural form of the electromagnetic spectrum that you receive when you're outside, there's 3 different forms of UV, UVA, B, and C. The increasing in the letters towards the middle of the alphabet, that UV light radiation becomes shorter and shorter wavelength and more toxic. So UVA is right around the shift to the ultraviolet from the blue spectrum, which of course is visible, and that's very common when you're outside. UVB is a shorter wavelength, but still well within the 300 in terms of nanometer range, high 300s. And that kind of UV light also is really important for like sunburning and sun tanning. And it also is intimately involved in the photolytic reactions and isomerization reactions that lead to vitamin D synthesis. So here we go. How's it work? There's a conformational equilibrium of a pre-vitamin D, and that involves a balance between an intramolecular and intermolecular electrostatic and steric interaction. All of this favoring this cis-Z-cis conformation that gives you the ultimate product. Okay, so you don't need to know the stereochemistry of that, but that's the way it works when they synthetically make vitamin D. That's how they do it with light. So to achieve the conformational equilibrium in situ, that is the natural production, it does require a restriction of a conformational flexibility so that isomerization and photolysis can occur. So you need a certain kind of flexibility, but you also need a spatial restrictive geometry. Where else are you going to get that but in the membrane, right? So vitamin D is synthesized in the membrane of dermal cells, okay? In fact, and specifically the epidermis. And that whole system with the macromolecular structure of the membrane enhances the photolytic process, which leads to a couple of isomerizations and ultimately of the parent compound, cholesterol. That's right, cholesterol, ultimately making vitamin D3. So provitamin D3, shown here, which is also known as 7-dehydrocholesterol, or 7-DHC, it's formed in the skin from the desaturation, you see, of cholesterol. So you're putting a double bond right in that ring structure there. See that? So it's the first thing that happens, okay? Next, what happens is the 7-DHC absorbs UVB light from the sun that induces an isomerization. Now what's happening here is you're getting a photolytic rupture of that bond there. You see that's been broken. A little bit more UV light then. You would go to something called tachysterol and lumesterol. This is in the manufacture of vitamin D3, okay? But in the natural environment, all you're going to get is this ring structure is going to swing over, and that is what vitamin D3 looks like. I think I got a better image of it later. But the movement of that ring structure relative to that carbon atom there is what is the isomerization. So you get a photolysis, you get breaking of that bond after a double bond is introduced to cholesterol. Then you get an isomerization, which is basically spontaneous. Okay. So once that happens, the rest of this structure, this slide, shows you that there's something called vitamin D binding protein, that DBP, and that binds vitamin D3 and it takes it directly into serum blood circulation. And that's how you receive your vitamin D from your skin. It's direct input. And the reason that vitamin D synthesis continues to occur when you're outside in the natural sunlight, which you should do a lot of, being outside is a good thing for you. All of this jargon about melanoma and worry about skin cancer is real, but for the most part, humans have evolved outside, and therefore we can receive a great deal of solar radiation and not get skin cancer. I want to be very aware of that. And I'm not promoting you to get skin cancer or telling you to just be outside all the time, although being outside more rather than less, I think is a good thing. But that's how you make vitamin D. And you make plenty of it because of the way the reaction occurs with the photolysis reaction and the movement through the DBP pathway. Now, there can be very rare inborn errors of metabolism where some of those reactions might not occur. But they're so rare, they're not really even in the textbooks. So you usually make enough vitamin D when the sun is out. Now, of course, in wintertime, or if you're way up by the North Pole or way down by the South Pole, and you get a lot of long shortened photo periods, like in their winters, then you might have a deficiency of vitamin D, and you might want to take a vitamin D supplement. But by and large, if you just live a normal life, you make a lot of vitamin D, you store a lot of it because it's a lipid. Vitamin D supplementation, which we're going to get into a little bit here, is actually not recommended except in rare cases, maybe during pregnancy, and if you actually have been diagnosed with a vitamin D deficiency, then that's a different story. Let's go to the next slide. All right, now I want to show you here a little bit more about what vitamin D is involved in. First of all, you get the 7-dehydrocholesterol we just saw, which is a provitamin D3. Sunlight, remember, opens up that ring. You get photolysis, a photolytic reaction. You make pre-vitamin D3, right? And then through a couple of cytochrome P27A1 and 27B1, now these are going to be reactions carried out probably in the endoplasmic reticulum, but also maybe in the mitochondrial membranes. You're going to make 125-dihydroxy vitamin D3, and then that particular form of D3, 125-dihydroxy D3, is going to bind to the vitamin D receptor. It's going to make a dimer with a retinoic acid, orphan retinoic acid receptor, a dimer of that, and it's going to bind to the vitamin D response element, which is going to be cis-acting for the transcription of genes. So that's how vitamin D3 acts like a good old steroid hormone. It works with another, not quite a steroid, but a retinoid, another lipid, retinoic acid. And the two of them together, when they're bound to their receptors, which float to the nucleus after ligand binding, will bind to that VDRE, or sometimes directly to a retinoic acid element in the DNA, open up that DNA, allow chromatin remodeling, and give you fresh transcription of genes. Now, what those genes do is myriad. So, for example, in keratinocytes, you get an increase in differentiation. You get an increase in cathelicidin production. In innate immune cells, like macrophages and dendritic cells, you regulate the maturation of the innate immune cells. There's multiple lineages that goes on there. I talked a lot about in my previous immunology lectures about how macrophages go through various transformations until they end up being either pro or anti-inflammatory, M1, M2 respectively. You also have dendritic cell maturation where they can act both essentially as a phagocytic cell, part of the innate immune response, but then they also ornament themselves, and then these C cells are the ones that most likely will communicate directly with T lymphocytes. Then altering T lymphocyte metabolism via changes in transcription factors, remember, the TBAD, and the various other transcription factors that are associated with THs, TH1, TH2, T cell lineages, or to the Treg cells, which would be the TBAT increases, and also TH17. Okay? And then it's going to give you either pro-inflammatory or very rarely in the Treg cells, anti-inflammatory cytokines, chemokines, growth factors, and transcription factors, which further regulate T cells, ultimately B cell activation, the production usually of some kind of immunoglobulins, IgM, IgA, IgG, etc., and then that transforming, those B cells transforming into natural plasma cells, right? And then the whole associated with complement. So there's both acquired and innate immune responses regulated by vitamin D. Okay, that's what I'm telling you. At the transcriptional level. There's also some post-transcriptional translational work that vitamin D does in the cell. I'm not going to talk about that this morning. Now, T cells, again, one of the things that this vitamin D response has been shown to do is decrease the ratio of Th1 to Th17, increases the ratio of Tregs to Th2. So that's generally a suppression of the immune response, generally a suppression of the immune response. And there you see the association on B cells, then plasma cells, a tanking of IgG and IgM, and overall a taking of that maturation to the plasma cells, right? So vitamin D is basically immunomodulatory in the way that it tips the balance more towards an innate immune response being functional, but even there's a lot of reorganization, recombination of activity. But the acquired immune response, T and B cells, that tends to be tuned down. Vitamin D also, of course, modulates angiogenesis and the synthesis of keratin for the growth of hair, of which apparently I still don't have a problem with. And so there's a lot of things vitamin D is involved in that you don't think about. Here I haven't even shown you calcium and phosphate, right? Bone mineralization. I think I'll show you that a little bit later. That's usually the poster child sort of thing you think about with vitamin D. Bone mineralization, definitely it's critical there. I'm just showing you that vitamin D is basically a steroid hormone, right? Not really a vitamin, also because you can synthesize it yourself. So a true vitamin means you don't synthesize it, it's essential. Vitamin D isn't really essential. All right. All right. Okay. I'm going to just make this whole thing a little bit smaller here. So A and D are lipids. That is retinoic acid and cholecalciferol, all are lipids. They're lipid soluble. They're vitamins that are lipids. Intake, metabolism, and transport are highly regulated because they bind to proteins. So the proteins have to dock onto receptors. You get the idea. Both of those vitamins perform functions that include vision for vitamin A, inflammatory responses, both of them, repair, both of them, bone mineralization, mostly D, calcium and phosphate availability, both, and alteration of gene expression, which I just showed you in a very generic sense. All right, now I want to draw your attention to this paper. It's a paper published in Journal of Biological Chemistry in 2013. Now we're getting into some actual science, not textbook biochemistry talk. Paper published 7 years ago. Right? There's an anti-inflammatory function of vitamin D, which I just alluded to. That's beyond calcium metabolism and bone health. VDR, which belongs to the nuclear receptor superfamily, the vitamin D receptor, VDR, dimerizes with that retinoic acid X receptor, that's the orphan receptor homologue, and regulates transcription via binding of the vitamin D response element I just showed you, which instantiates coactivators and HATs. Remember, those are histone acetyltransferases. So when you activate or you allow HAT to function, that means you're making euchromatin. So basically you're getting chromatin remodeling towards that euchromatin, not tructure, sorry, that S was left off. I really need to be more careful about misspelling. So the glucocorticoid receptor also dimerizes and binds to glucocorticoid responsive elements, which are known as GREs, right? Not graduate record exams, but glucocorticoid receptor elements. That's what the E stands for. And they regulate expression of other specific genes, including MAP kinase phosphatase 1, MKP1. MKP1 belongs to a family of phosphatases that inactivate the MAP kinases because they strip off the phosphate. Most of the time when you see a cascade of kinases, a kinase cascade, K then C, right? What you get is a phosphorylation of the downstream kinases. So you get a kinase, and then you get that kinase to phosphorylate other kinases. And ultimately you might get a transcriptional event or some other kind of subcellular phenomenon that's altered by those kinase cascades. So obviously if you strip off the phosphate via an enzyme called the phosphatase, you stop the pathway cold in its tracks. It no longer moves forward, right? Sometimes it goes in the opposite direction, but at least it stops it. So one way to shut down kinase cascades, signal transduction cascades associated with phosphorylation of proteins on the various amino acid residues that will receive a phosphate, tyrosine, threonine, serine come to mind. When that occurs, that stops whatever that process is. So this glucocorticoid is going to induce a phosphatase, so it's going to shut down the MAP kinase pathway. Get that? Good. So vitamin D deficiency. People that had vitamin D deficiency were twofold higher in those reported glucocorticoid use compared with those without steroid use. Now, that's an interesting thing. So you get vitamin D deficiency, twofold higher in those that have been using chronically glucocorticoids like cortisol, hydrocortisone, right? All right. As compared to those that don't have any steroid use. Okay, so that's interesting. And the odds ratio there is 2.36, so that's almost 2.4-fold higher, right? Pretty good confidence interval there, 95% with the data. And so chronic glucocorticoid might associate with vitamin D deficiency, regardless of how much sunlight you get. Asthmatics, people with asthma, with low serum vitamin D, have impaired lung function, increased airway hyperactivity, and of course, increased corticosteroid requirements. They usually don't make enough, and often they're given that as an inhalant, right, or an injectable. Okay? It's one of the things when people have asthma, they're given is corticosteroids, right? Now, one of the ways that works is to tank the immune response, right? It's one of the things corticosteroids do, right? All right. Dexamethasone, very commonly prescribed, Dex, induced MKP1 expression. Remember, that's the phosphatase from the glucocorticoid induction, which is a biomarker that's used as a biomarker for how much Dex you need when you're titrating Dex in a patient. You do this if you want to run a blood panel for MKP1 expression. Biomarker for GC response, which you can do this, of course, in animals, 24 hours a day, is significantly increased as serum vitamin D levels rise, suggesting that vitamin D may enhance glucocorticoid responsive effectiveness or efficacy. So here's one more thing you need to know. There's an aspect here which relates to GM-CSF. I'll tell you what that is in a minute. Okay. GM-CSF is going to be as a protein. Now, GM-CSF mediated vitamin D enhancement of glucocorticoid induced phosphatase transcription Remember, these are transcriptional phenomena. In monocytes, now you're into monocytes. What are those? Those are innate immune cells, right? Via an increased production of a mediator complex subunit 14. Sorry, I didn't give it that name. Someone else did. Med14. Okay, that's a GM-CSF mediated vitamin D enhancing, glucocorticoid inducing phosphatase expression in monocytes, ultimately making this complex called the mediator complex subunit 14. Okay. Now, recruitment of vitamin D and this Med14, 4.7 kilobases upstream. I'm talking about what? Chromatin remodeling. We're writing the DNA now in the chromatin of the human MKP1 gene. That's the phosphatase. Transcription start site, right there at the 5' end of that transcription start site, probably near the cat region. Enhanced binding. Now, this is all enhancing. Vitamin D is enhancing glucocorticoid receptor and histone H4 interactions at that chromatin. You're getting the glucocorticoid receptor binding, the GC binding, and you're also triggering histone 4 acetylation at that 4.6 kilobase base pair portion of the promoter region, which is all part of the glucocorticoid response element, the GRE, just telling you about. And that's all to turn on MKP1 promoter in the presence of GM-CSF. Okay, that's good. So, a little bit about GM-CSF. Granulocyte macrophage. So there is the reason I didn't tell you before. So now that you'll know it. This is from a paper published way back in 2006. So this is what I do. This is what Dr. Guerra does for you in Authentic Biochemistry, both video and audio. I go into the primary scientific literature and I pull papers that may not be the initial paper describing some system, pathway, etiology, pathology, etc., but one that is very descriptive and useful for you to build your knowledge base. That's what I've done here. It's a 2006 paper published, Cell Research, and you can see the citation there. So GM-CSF, that stands for colony stimulating factor, is an important hemopoietic. That means it turns on the synthesis of cells involved in transport, movement, whatever in the blood, hemopoietic factor, and immune modulator. So it's involved in the synthesis or the maturation of cells involved in hemopoiesis, right? Those cells you find in circulation in the blood. So GM-CSF also has profound effects on the functional activities of various circulating leukocytes. We just mentioned one, right? The monocyte. Leukocytes are white blood cells, not just red blood. So GM-CSF works with red blood cells, but also works with white blood cells. That's what we're telling here. Okay, of course. It is produced by a variety of cell types, including T cells, macrophages, endothelial cells, fibroblasts, upon receiving some kind of other exogenous immune stimuli, multiple stimulus. Although GM-CSF is produced locally, can act as a paracrine fashion to recruit circulating neutrophils, monocytes, and lymphocytes, that's T and B cells now, to enhance their functions in any kind of host defense that's being marshaled. Recent intensive investigations are centered on the application of using GM-CSF, that protein, that polypeptide, as an immune adjuvant for its ability to increase dendritic cell maturation and function, as well as on the macrophage lineage. Okay? So now you know something more about granulocyte macrophage colony stimulating factor than you do a minute ago. Of course. Oops, sorry. So, again, vitamin D, non-essential. Human metabolism provides this nutrient. I just showed that to you. And sunlight. Via reaction involving certain wavelengths, right? Precursor is skin-associated cholesterol. I told you that. Cholesterol, that's correct. Subsequent conversion of bioactive vitamin D. There are two hydroxylation reactions also. Notice that last paper talked about 125 dihydroxy vitamin D. That's a very potent bioactive form of it. Makes it a little bit more water soluble with those two hydroxyl groups. You have a lot of those reactions occurring in two vital organs, the liver and the kidney. Okay. So there's our gosterol, another form of sterol that we don't synthesize, making pre-D2 and D2 then finally. This is how it's manufactured and how you get vitamin D in a pill form. And there's 7-dehydrocholesterol. Again, we've seen this pathway before. And you can actually synthesize it in vitro by using light, like we just saw, and then heating it up so you get that isomerization there. So you get the movement, that whole ring structure flips around on that carbon. See how that moves. Right. So that's the photolysis of gasterol, or 7-dehydrocholesterol, to D2, also known as ergocalciferol. Fungi make that form of it. And vitamin D3, which is how mammals make it, that's also known as cholecalciferol. Chol for what? Cholesterol. And the intermediate form after photolysis, which undergoes a thermal activated isomerization to the final form of D3. The rotation around the A ring, that's the A ring there, down there, puts the 3-beta hydroxyl group, that's this fellow right here, right, into a different orientation with respect to the plane of the A ring in the other form of vitamin D that's yet to make that isomerization in the pre-D3, right? And that's the fully bioactive form. Then you can further hydroxylate. That's the point we're making here. All right, so it's just showing you the same reactions, just showing you some of the chemistry. There's 7-dehydrocholesterol running through. There's D3. There's the 25-hydroxy D3, and there's 125, and there's 2425. 2425, which we really don't know the function of. It might be a degradation form, but the 125-dihydroxy definitely has very potent biological activity, and it's got a special name. It's called calcitriol, right? So, because there's 3 hydroxyl groups, citriol, 3 alcohol groups. Okay, very potent, biologically active form of vitamin D that you can get in pill form, and that you synthesize de novo in the liver and the kidney. All right, it's just showing you again something. What happens is you get in circulation, the 1-alpha-25-hydroxy dihydroxy D3 comes in. It binds to its receptor in the nucleus. In very simple terms, I told you the more complex terms 3 slides ago. It causes that chromatin remodeling. Remember we talked about that. It makes a transcription. It enhances transcriptional events, and ultimately those proteins are synthesized, and those proteins go on to do whatever they're going to do. For example, the phosphatase, right? The glucocorticoid receptors modulating, remember D3 also helps modulate. Please keep that in mind. D3, glucocorticoid, right? Phosphatase, right? Okay. Now, one of the things that does is allow for calcium to move in, and that indeed is one of the hallmarks of vitamin D. That's why they're showing you here. So you get calcium binding proteins at the brush border, and you're able to get uptake of calcium ions. So again, just another pathway slide that I throw in there, showing you UVB. I told you it's UV light at a lower nanometer wavelength. That's 290 to 315, and that's what's triggering these responses here. There's vitamin D going to the liver, making D25, and then it can be catabolized by these cytochrome oxidases, but also it can be further metabolized into the 125 dihydroxy. And that also can be further catabolized. But the 25 and the 125 are involved in calcium and phosphate uptake using these kinds of transcription factors to help regulate that process as the transcription translation products. It also, a parathyroid hormone also functions to control this. And in fact, high levels of phosphorus or calcium or FGF23 will actually block the activity of the 25 hydroxyvitamin D alpha-1 hydroxylase, making the more potent 1,25 dihydroxyvitamin D3. So build up a free phosphate, build up a free calcium. FGF, that's the fibrosis growth factor 23, will negatively impact the final net synthesis of the most bioactive form, that calcitriol, where parathyroid hormone actually promotes it. We've talked a lot about hormones in the last 8 or 9 lectures. This is where you start to see hormone crosstalk. There, once again, is the same pathway. All right. Showing you again how it functions. This is just another artist's depiction of it. I'm showing you here because there's a lot of cytochrome P450 enzymes involved in some of this metabolism, and they're all vital, and that means that they're all membrane associated. Again, what does vitamin D do? It's a hormone, binds proteins carried to target organs. It's involved in bone growth, particularly calcium and phosphorus absorption, and therefore it enhances that absorption, so for bone mineralization. Other roles, I just showed you transcription factors, a whole host of central nervous system factors, which I'm not talking about today, but which I have done in the past, and I certainly will in the future if someone asks me. Okay. So, from the gut, you get calcium and phosphate, right? And you need to get that calcium and phosphate to the bone. Vitamin 125 dihydroxy D3 facilitates that process. The bone also demineralizes, so you get a lot of this calcium movement. You have to secrete it out of the system. That goes through the kidney and out with the urine. 125 dihydroxy D also controls this process. It basically keeps calcium and phosphate levels at a homeostatic sort of teeter-totter common balance between those two, the cation calcium and the anion phosphate. So you have plenty of both calcium and phosphate for bone remineralization, okay? And the gut's involved in this whole process, right? So that's the important thing, because the gut's a reservoir for calcium and phosphate. And remember that the kidney's constantly functioning to regulate what's flowing in the blood, right? It's filtrating the blood through the glomerular process. And this is ultimately linked. That's why kidney damage, kidney disease will inhibit or decrease bone mineralization. This can often happen in aging in women. That's osteoporosis. That's one mechanism. Parathyroid glands, we already told you, the PTH is very, very, very pro-stimulatory for bone mineralization. So vitamin D deficiency, overt indication, we just don't see it anymore. Years and years ago, when there were people living during the early phases of the Industrial Revolution, or just in cities that have a lot of air pollution, skyscrapers, or just in northern cities where there's less incident light during the day because of a lot of cloud cover, because of the moisture in the air. So a decrease in direct UVB exposure could limit the amount of vitamin D production. And before they started fortifying cow's milk with vitamin D, which is what they do now, of course, you did have sporadic rickets forming. This is a bow-legged sort of presentation in humans. It's the direct result of vitamin D deficiency. I have a personal member of my family that suffered from rickets as a young boy. My grandpa, Albert Guerra, who grew up in Chicago. He was born in 1900, so you can get the idea that he was growing up in Chicago when Upton Sinclair was talking about when he was writing The Jungle, right, in the early part of the 20th century, 1910s, early 1920s. And a lot of children ended up with those bone deformities. And that was about the time the FDA came out and decided to start fortifying milk with vitamin D. Now we've cleaned up the pollution quite a bit. So if you go to Chicago, for example, where my grandfather grew up, or any other major city in the United States anyways, maybe not in China, maybe not in Mexico, but the United States, you're not going to get nearly that kind of pollution. And because of that, you're probably still getting enough vitamin D synthesis directly in the epidermis. So sometimes people even talk about removing vitamin D from milk because maybe we're getting too much of it. Because you can have problems with excess vitamin D. You might understand why, because well as control over transcription. Right? Through our diseases, I just told you, rickets, bones fail to calcify normally. The bones bend too easily. It affects children, and then they go on with life with that bow-legged presentation. And you also get osteomalacia. That's an insufficient bone mineralization. It affects mostly the elderly. Bones become soft, flexible, brittle, and deformed. People can fall then. You know, anybody over the age of, say, 80, falls are a major cause of morbidity and mortality. Right? So it all comes together at the end. Clinical manifestations of D deficiency, which is pretty rare actually. Osteoporosis, but I told you, postmenopausal women can develop osteoporosis. That's a loss of calcium from the bones. That can be a result of or concomitant with fractures, multiple fractures because of falling. Vitamin D deficiency, especially likely in the elderly because you get a reduced ability to make and activate vitamin D. Why? Because the elderly are less likely to be outside. That's one reason. And because of malabsorption. That's another good reason in the gut. There's more, but those two will probably get you there. And it says right there, shut indoors, organ function failure, kidney, liver, and of course the intestine. And they also drink less vitamin D fortified milk. And so do I. I don't drink any milk whatsoever, but that's used to be considered one of the contributing factors. And that's when they started considering vitamin D supplementation in the form of vitamins. Back in the 70s, I remember when that started coming on, when I was a teenager. Well, at the beginning of the 70s anyway. All right. So vitamin D toxicity is also known, but it's pretty rare. You get hypervitaminosis. You've heard of this for vitamin A, but sometimes it can happen with vitamin D, and that can happen directly from overconsumption, too much vitamin D in vitamin form, pill form. What it does, it raises blood calcium concentrations. It can form stones in soft tissues, and they may harden blood vessels, leading to increased morbidity and mortality. So you don't want a vitamin D toxicity. And that's a chronic event. So it's the kind of thing where you're not going to notice it until much later when you have a disease associated with the toxicity. And sometimes it's misdiagnosed. So, and it may be more misdiagnosed than we even know. Vitamin D recommendations. See, I'm giving you some vitamin D discussion here. Few food sources, oily fish and egg yolks are good. Fortified milk, Recommendations are difficult to meet without sunlight and supplementation or fortification. In other words, we don't really know how much sunlight you're getting. That's a dose-response curve on its own. Recommendations may be unsubstantiated, the high recommendations that are often suggested by the FDA. Sun exposure, there's no risk of toxicity there because of that DBP, or that vitamin D binding protein, DBD, right? DBP, now I said it first time. Vitamin D production varies with skin color, latitude, obviously, season, and time of day. They all play a role. So someone like me who tans a lot, I probably absorb a lot of vitamin D, but because I tan, I might actually absorb less, or the curve of synthesis might decrease, and then therefore ultimately absorption. But it's not likely that most people who are healthy have any problem synthesizing vitamin D unless you're well advanced into your 80s. So here's a paper that's interesting. Vitamin D supplementation to prevent acute respiratory tract infections. Systematic review and meta-analysis of individual participant data. You can see the paper was published in 2017 in the BMJ, British Medical Journal. In this recent analytical view, vitamin D supplementation was demonstrated to be narrowly beneficial. This paper was published about 3 years ago. Only those severely deficient in 25-hydroxy-D, remember it's the precursor to the cell-based 1,25-dihydroxy, calcitriol, shows positive benefit or lowered risk from acute upper respiratory tract infection. Okay, that's interesting because that feeds back into this coronavirus discussion. I'm going to get it in a moment. This benefit was far less significant in patients with a normal range of 25-hydroxy-D. Okay. So maybe there's something there. So vitamin D deficiency, is there really a pandemic? That is of the vitamin D deficiency, right? It's a funny term, but that's what these authors chose to publish in the New England Journal of Medicine back in 2016. You see the citation there. In 2011, the Institute of Medicine recommendations, RDA, for deficiency of vitamin D, that's the 25-hydroxy form, was set to correspond to below 20 nanogram per milliliter or 50 nanomole per liter of blood. This recommendation has been refuted as a misrepresentation and may have led to overdiagnosis and inappropriate D-supplementation, since it assumed negligible sunlight-mediated synthesis. See, practically rules it out. It says, well, we're not going to add that to our algorithm. Now, that is absolutely absurd, right? Because it's pretty hard not to get some sunlight exposure, right? Pretty darn hard. But this recommendation that the FDA was using, their RDA, basically acted like that wasn't part of the process, where that is the biological process, right? So sometimes you got to wonder. All right. So that was considered by these people, and I would agree, a misappropriation of RDA values, which obfuscate the true evidence. Fortunately, you will find this in publication and as recommendations by federal agencies. Yes, they make mistakes. They are just human beings. Scientists are just people, sometimes wearing lab coats. All right. Vitamin D supplementation likely does more harms than good in the general population. That's what these people decided in this publication. Now, there's still some back and forth. And certainly if you're diagnosed with vitamin D deficiency, if you've done a blood panel test and your physician says, yes, you are vitamin D deficient, they're going to put you on vitamin D supplements, and that's perfectly correct, right? That's kosher. But if you prophylactically take vitamin D, especially massive doses, this is where you can run into problems because you already may have sufficient vitamin D in circulation, regardless of how much you sunbathe at the beach or when you're mowing the lawn or cutting wood. Now, the paper published in 2016. Effectiveness of vitamin D supplementation for cardiovascular health outcomes. Okay. Does vitamin D supplementation improve cardiovascular conditions like blood pressure and atherosclerosis? Evidence found in this paper in randomized controlled trials, they're called RCTs, of course, is inconsistent. Meta-analysis, this is what this paper studied, of several RCTs does not support vitamin D supplementation. Okay, this paper finally came out in 2017, right? It EPUB'd in 2016 in December, but it came out in print form and electronic form, downloadable form, just in January of 2017, just 3.5 years ago. Vitamin D supplementation is ineffective in improving cardiovascular health, regardless, or I would say irregardless, of like flammable and inflammable, right? Of presence or absence of vitamin D deficiency. Now that was a pretty remarkable, striking discussion or proposition in this paper. But that's what they found when they did a meta-analysis of all these RCTs, when it was actually studied. Doesn't look like it helps even if you have a vitamin D deficiency, right? In terms of cardiovascular health. May increase vitamin D if you're vitamin D deficient, but it might not have any effect on cardiovascular health. That's the point of a lot of vitamin D supplementation that was going on in the 2000s. Here's a paper published in BMC Rheumatology, Volume 4, Article 4, this year. Very recently, in fact. Yep. Patients with rheumatoid arthritis have increased cardiovascular disease and mortality risk. This is well known. Remember, rheumatoid arthritis is one of these pro-inflammatory diseases which are autoimmune in nature. Autoimmune pro-inflammatory diseases. Patients with RA, rheumatoid arthritis, are also prophylactically prescribed glucocorticoids. Why? Because it's an inflammatory disease. I just told you that. Right? Which are associated with increased risk of mortality. What shows some increase in mortality risk? The glucocorticoids, the very compounds that are used to suppress the immune response. For patients who have concomitant type 2 diabetes, which is often coming secondarily as you age, especially in obese populations, glucocorticoids, immunosuppressive glucocorticoids that people receive, like hydrocortisone, are known to worsen glycemic control. Because remember what glucocorticoids do. Why are they called that? Especially people just call them corticosteroids. And you think about the few that are sent that are sent to you via prescription, right? But a glucocorticoid also induces gluconeogenesis, right? More glucose in the blood. I talked about that extensively last lecture. Please go back and notice that. So they worsen glycemic control in diabetics. That's not good. And hence, they may further increase cardiovascular disease and mortality. See how that functions? So the study aimed to understand the relationship between glucocorticoids, type 2 diabetes, which is a late onset, and mortality directly. That's the endpoint they wanted to look at in patients with diagnosed rheumatoid arthritis. Okay, so that's where we're at with this paper. What did the data show? In RA patients without diabetes, glucocorticoid use had a 4.4-fold increase all-cause mortality. Right, that's the ratio there. That's the RR ratio, right? Mortality ratio. With a 95% confidence interval compared with no glucocorticoid administration. So these are just your straight up autoimmune, pro-inflammatory responding rheumatoid arthritic patients. Okay? Glucocorticoid increased all-cause mortality in this huge population that was looked at. This is basically a meta-analysis. Now, those with rheumatoid arthritis and type 2 diabetes, which is really the purpose of this paper, because the first point there, right, basically a proposition that has evidence, so it could be called a conclusion, okay, in somewhat of quotation marks, but it's a conclusion, a medical conclusion anyway, about as good as they get. Those with rheumatoid arthritis and type 2 diabetes had a lower ratio of mortality for GC use, only 3.0 times rather than the 4.4 without it. However, that number masks something because those with rheumatoid arthritis and type 2 diabetes, when they have both diseases diagnosed, actually had a higher. Now, this is a different ratio. This is a ratio which basically looks at the increase of death on top of adding another variant associated with GC use, glucocorticoid use, because of their higher baseline. So if you have both diseases, you have a higher baseline of mortality. And overall, that kick in glucocorticoid looks smaller than without type 2 diabetes, but it's still overall larger. You see it. So that's how you got to be very careful with statistics you look at and how the data is analyzed. That's why you have to verify the evidence, if it ever makes it to the level of evidence, which is pure data. In those with rheumatoid arthritis and type 2 diabetes, glucocorticoid use was associated with an additional 46.7 deaths per 1,000 person years, or PYRS, okay, compared to non-use. So this is a pretty important thing to keep in mind. That means there's a lot of people going around with disease that are on basically a ready, steady diet of glucocorticoid. And when you look at the data, if you're a rheumatoid arthritic, and you also have the complication of type 2 diabetes, you may not have any extra presentation of the disease, but when they look at the data, a meta-analysis of people with those two comorbidity diseases, they're pretty severe diseases. One of them is straight up autoimmune, the RA, right? High inflammation. And we also know type 2 diabetes is high inflammation. That's why they're giving the glucocorticoid, right? Yeah. Well, look at what happens when you're on a chronic glucocorticoid, according to this 2020 paper just published, right? Not good. Right. So that's information I'm trying to give you as my audience. It's right out of the publication record. Very, very, very recent publication. So what's the conclusion these people make and that I can make from it for them too? Glucocorticoid use was associated with a higher mortality rate in diagnosed rheumatoid arthritis patients with comorbid diabetes compared to people without diabetes. Straight up. These authors warn that clinicians need to be aware of the higher baseline risk in the diabetic patients when they prescribe, and of course it's also going to be titration of the glucocorticoid in patients with the pre-existing rheumatoid arthritis, and then of course with this comorbid diabetes. So that's all their paper said there. So I'm going to give you some dialectical considerations to leave you with. They are my considerations. They are propositions. They're not meant to be medical advice. They're just propositions from what we've seen so far in the published data, okay, that I've put together with looking at 30, 40, maybe different publications, and then trying to find papers that don't find this, right? So here's a consensus set of dialectical considerations. Patients with pre-pathologies and diagnosed diseases are the ones most likely to suffer severe morbidity and sometimes death from infections, especially those associated with the upper respiratory tract, such as this Chinese coronavirus, this COVID-19. Older people, you've heard this I'm sure many times, those over 75, really almost over 80, with a common chronic disease associated with obesity, like COPD, that's chronic obstructive pulmonary disease, RDS, that is respiratory distress syndrome, so it's not a frank disease, it's just generally respiratory distress upon presentation, or chronic illness, which is what happens to a lot of older people, and cardiovascular disease of all paints and colors, and cancer of all types and descriptions, especially also when you think about cancer and cardiovascular disease, and then the drugs that are used in those diseases, and the drugs that are given subsequent to surgeries. I'll get to that in a moment. They're all highly included in this relatively narrow margin of the general population. Clinical trials have repeatedly demonstrated that certain forms of the anticoagulant heparin, and I've talked about this in these lecture series, can cause thrombocytopenia, which has been associated with the coronavirus. And that can lead to, of course, to rapid death, right, because of blood clotting, even though heparin is an anticoagulant. And that's because there's a hyperimmune response that's used to be taught in medical schools, still should be, which is, of course, the heparin-induced thrombocytopenia, or HIT. Now we see that glucocorticoids can also increase the chance of death in patients with rheumatoid arthritis and comorbid diabetes, or just with rheumatoid arthritis alone. We just saw that paper, and that paper is not the only one. It's after a flood of other papers going way back at least a decade. Okay, these people aren't looking at viruses, they're looking at the use of glucocorticoids, and in one of those cases, the use of heparin. And because glucocorticoids are immune suppressive, and the heparin is used to prevent blood clots after surgeries. What kind of surgeries? Most surgeries. It's a major anticoagulant, but particularly, like, for example, think about when people have open heart surgery, or they're just getting something like angioplasty, or maybe stents being put in there. They want to prevent blood clotting, heparin, and they want to prevent a hyperimmune response because they put in something foreign like stents, glucocorticoid. You get the idea, right? You don't want a hyperimmune response after surgery. But you do want healing. Healing, though, often with the innate immune response. Right? So, the practice of massive glucocorticoid administration in presenting COPD or respiratory distress syndrome incoming patients, also linked perhaps to, say, to an infection like this Chinese coronavirus, may need to be reevaluated. This is just a proposition I'm making based on the data I've looked at. No recommendation, just a proposition. In fact, antibiotic prophylactic therapy, which is also included here, may also need to be scrutinized, as that can lead to antibiotic-resistant virulent bacterial pneumonia, because we have a lot of antibiotic-resistant bacteria in clinics and in hospitals, right? These so-called nosocomial infections, right? And that's especially in a hospital setting. So I want you to consider these as they're just considerations, they're just propositions, but they're based on what I've found in the scientific evidence. As I've been giving you just general lectures on steroids. Remember that vitamin D is a steroid. Remember that glucocorticoids are naturally produced steroids. Vitamin D is also naturally synthesized in the body. Then think about it. Sometimes a vitamin D supplementation can be a pre-existing condition in a patient with not something that you pick up on a history when you're doing an intake for a patient, or even when you have a patient, say, in the clinic, you're just talking to them. You may not know they're on a vitamin D supplement. You may not know that they are hypovitamin D. Okay? It might not be things that are cleared from a history. Likewise, the glucocorticoids are very commonly administered for all kinds of immune diseases, autoimmune diseases, asthma, for example. And again, things like lupus and rheumatoid arthritis. A lot of other kinds of autoimmune diseases, which I've covered in previous lectures. I want you to keep that in mind. There's a population of people on these drugs, and then they're presenting to a clinic with, say, a new infection, and then they're given more glucocorticoid, or they're given heparin. See how that works? All right. So I'm going to leave you with that. And next time we're going to start talking more about the rest of the steroid hormones. We're going to talk more about reproductive biology here. Maybe I'll get some input from my son who works in that area, Damien. And then move on from there. Once I finish steroids, and I think we've done a good job, then we'll probably go back and spend more time on vitamin D because it's a fascinating topic. Just straight up physiology and pathophysiology. So I'm just going to close this lecture now and hope that you're having a good Friday, the 22nd of May, and that I will be back with you pretty soon on a further discussion of steroids. If you have any questions, any comments, please send them to me at my email address, djgphd@gmail.com, and I will try to get to them as soon as I can. Please remember, this is a free lecture. What I'm trying to do for the public, for my individual audience, is to give you information directly from the scientific literature. Try to synthesize and organize that in a way that you can understand how there are associations and networks from pharmaceutical drugs, non-pharmaceutical drugs, alcohol, aging itself, and then all the comorbidities and diseases and pathologies that one may accrue as one ages or just lives through life. Now, all of those various biological, biomedical systems can come together to give discrete individual specificities of health for individual people. And the histories of that then can organize around how any subsequent pharmacotherapy or surgery, etc., may be something that will ultimately will result in your life. So thank you very much for your attention, and bye for now.